we're on time. We're going to have some questions at the end. The next speaker is Professor Richard Osborne, who is another multi-millionaire holder of research funds. He's got too many degrees to mention prior to doing his PhD in cancer survival, and has found his niche in public health. He's Professor of Public Health at Deakin University, at the Melbourne campus. And he's taken on such reforms as the orthopaedic waiting list and improving health literacy. He's going to talk to us about health literacy and fit for purpose research with a social justice framework.
Thank you for that kind introduction. I think it's because I'm a naive country boy that I take off on orthopods just as a basic scientist in the Royal Melbourne Hospital. A project that should never have happened. I'd love to talk about that, but I'll try to bring the learnings of that into my presentation today about health literacy and about really how to make a difference. How does this beast work? Oh, the big green button that says an arrow. Okay. So patients and professionals often see the world differently. I don't think anyone in the room would argue against that motherhood statement. And here's an example. Harold and Bert looking for socks and underpants online. Have a little think about that. We have our holy grail of having the patients around us so served well by us with our pearls of knowledge and systems that just enable all our patients to be easily managed. Okay, so reflect on that a little bit. I started off working in the area of patient education and self-management and really trying to work out, well, how can we organise the community to have command over the healthcare system and all their treatments and our command over you guys? How can we organise ordinary citizens to have access to opportunities to engage in health activities, simply access? How can they have the confidence to take initiative? And how can we ensure there's supportive environments there that they can engage and maintain their healthy behaviours? I guess I call that paragraph like healthcare utopia. Right, we'd like all our citizens to be completely enabled and empowered to do that, but unfortunately, many people don't have the capacity to identify, even recognise there's a health message in front of them, nor do they have the capacity to understand that health information, nor do they have access to information about health and healthcare professionals, and nor do they have the faculties to distinguish correct and useful information from incorrect and unimportant information. Then perhaps we'd like them to have a whole range of self-management skills, that they have positive and active engagement in their life, they have good skills and techniques, they can do self-monitoring, have insight, they have socially integrated and support, they've got health-directed activities all the time, they've got constructive attitudes and approaches, they've got great navigation skills of the healthcare system, and they've got really terrific emotional well-being. With that, they have the chance to do some more fancy things like action planning and problem solving, and after that, they can reach utopia, perhaps. I developed a questionnaire called the Health Education Impact Questionnaire, and these are the scales there. I did this by doing something very unusual. I talked to punters, I talked to patients. I got so frustrated with social cognitive theory, self-efficacy, so frustrated with Albert Bandura's stuff I couldn't understand at all, and really frustrated with one-size-fits-all chronic disease self-management program, which has been promulgated worldwide by Kate Lorig. So I went and asked punters, what do you think are the things that you need to be able to engage? And I got the opportunity to travel around the world, and it's in 20 countries, lots of languages. So it became the national evaluation tool in UK. It's really quite common. You can never be a prophet in your own land, so it's only used to a certain degree in Australia. In fact, Kate Lorig's program from Stanford only started to be implemented in the States a couple of years ago, 20 years later. But the more I engaged in evaluating self-management chronic disease programs around the world, the more I see it was mainly the worried white well women taking part. It was the very enabled people who could come and take part in our initiatives. And then I was introduced to the concept of health literacy. This stuff down here. Papers are coming out here. Here's a very influential bunch of authors from the US. New federal policy initiatives to boost health literacy can help the nation move beyond the cycle of costly crisis care. Another one here, poor patient literacy hampers healthcare. All this sort of gels in some ways for you, I'm sure. And health literacy, as an academic, I do need to give you a definition, of course, and here's 5 of the 10 or 20 that's out there. Academics love to put out a definition, gets them papers, they get cited, they get grants, and off they go. We mainly use the one from the World Health Organization there at the top, and health literacy is the fundamentals about a person's ability to understand, access, engage, and use health information, health services. A number of countries now have pretty cool policies. This was released just last month from Scotland. A health literacy action plan for Scotland, making it easy. That's a light touch policy, pretty cool. We released from the European Office of the WHO, health literacy, the solid facts. Again, getting clarity about patient enablement and system enablement, and some of the more fundamental stuff coming out of the US. Here's something from the Department of Health and Human Services, the CDC. And just last month also in Australia. Hopefully you'll have a good look at this. This is from the Australian Commission on Quality and Safety in Healthcare. It's Australia's new premier policy document on health literacy. Very cool. But all these only go so far. Mainly they're telling us that there's a problem out there, and if I tell you there's a problem, you say, well, get off the stage, Richard, you're not telling me anything new. So I'll try and work through some solutions here. So despite there being a whole lot of different policies, we've been invited by the WHO to write a policy and toolkit for low and middle-income countries about, yeah, we know there's a problem, but what to do about it. So working across Myanmar and India and Thailand and Indonesia, our programs are beginning to happen. So without health literacy, if a person does not have adequate health literacy, or the health worker is unaware of a person's health literacy level, we cannot generate person-centred care. We're living in a person-centred care environment, aren't we? We want to achieve that. I'm a bit of an advocate of clinician-centred care, actually. I'm a bit of a heretic in many ways, because our frontline practitioners who have been there for years and years and years, they're in that job because they love their work, they love their community, they want to be there, they're there for their people. They have profound knowledge and interest and capability and pearls of knowledge we just don't know about collectively. And that's the theme of this talk. So a bad outcome, if you develop an ehealth interventional system and attempt to implement it without considering the needs and capabilities of users and how they will participate across the whole system, you're at risk of reducing social quality and health, of course. It's the enabled person who come forward. A little bit of a cheeky tautology. It's good for those people it's good for. It's good for those people it's good for. So I need to keep working on what is this definition of health literacy. There's 2 ways. You can read those academic definitions, which only go so far because they're written by academics, or you could look at how it's being measured. So I'll just quickly show you. This is one of the tools, the realm, a list of increasingly difficult words, and if a person pronounces these correctly, they're going to point towards their health literacy, irrespective if they understand what the word means or not. So this is hopefully going out of favour, given some of our reviews of this tool and others. This is the Toffler test of functional health literacy, the most used tool. Here is a medication label, and the person's asked some questions about it. They're also asked to fill in this modified closed kind of procedure. Your doctor has sent you to have a blank X-ray. So if you can't read, you can't even do the test. So there's a bit of a problem with that. It takes a long time to administer. Here's the shorter one to administer. This is an ice cream label, and a person's given this, and they're asked a couple of questions. If you eat the entire container, how many calories will you eat? I'm actually dyslexic and I freak out with these sort of things. You may have guessed it's 1,000. So we applied all these measures in Victoria in a population-based sample, and we found that somewhere between 7 and 26% of people have low health literacy given the scoring system. Then also from a national survey in Australia, about 60% of people have low health literacy. When you go into anyone's office who you want money from and you tell them that the health literacy level is somewhere between 7% and 60%, they ask you to leave immediately because come back when you know what you're talking about. So so health literacy from those fancy definitions before, it's much more about abilities and access and empowerment. A lot of the American tools, a lot of research you'll see out there is really down the bottom there. Does the person have the language, the vocabulary? Do they have knowledge? And then perhaps more fancy skills. And then empowerment and agency. Is it okay to ask a doctor a question? Is that is it culturally appropriate? There's a whole range of supportive and determining structures for a person about trust and faith. The emotional status, cultural work. Some of our work in India where women don't have the sense that it's okay even to leave the household to go and get a diagnosis of their cancer. They end up with late diagnosis of cancer. So all these things need to be considered in patient empowerment and enablement across the system. So despite most of the work being done with these very blunt measures, which mainly measuring reading ability and numeracy, low health literacy is linked to inadequate knowledge about health and healthcare system, increased hospitalisation, poor access and utilisation of health services, and people with low health literacy have been up to 3 times more likely to experience a poor health event. So we need a new questionnaire to measure health literacy from the patient's perspective, a bit like the experience we had with the health education impact earlier. So how can I truly get the patient's perspective? How can I really do that? But what about the practitioner's perspective and the policymaker too? And if anyone has ever developed a questionnaire, you know what the first thing to do when you go to develop one. There's someone nodding and you know this is the first thing you do. It's a horrendous exercise. It takes 3 or 4 years because our tools are designed to make decisions about programs, funding decisions. Some of our tools are used in global trials of influenza and they make billion-dollar decisions with multinational companies. So our tools are designed to, I can stand with hand on my heart and say, yes, Minister, this program works or it doesn't work. So we have enormous responsibility here from the individual patient level and the program level about understanding our programs and their value and who can and can't take part in them. But in developing a questionnaire, I won't go through all the details, but if you get the first step wrong, everything else is wrong. Doesn't matter how fantastic your statistics are and how big your sample is, if the idea is wrong in the first place, everything else is wrong. So we use a process called concept mapping. We do brainstorming with ordinary, average, everyday consumers, not ones usually on the committees, but the ones who are randomly drawn from the community, create an incredibly safe environment, allow them to express themselves given a very open statement. Here's the open statement to generate our health literacy questionnaire. Thinking about your experiences in trying to look after your health or the health of your family, what abilities does a person need to have to be able to get and use all the information they need? So this is workshopped and normal group technique and very safe environment. And this is what they come up with. So the researchers on the side, this is what the consumers and policymakers and practitioners come up with. So this is the new health literacy. It's operationalised from the patient and the policymaker and the clinician's perspective. I'll just read through the 9 very quickly. Feeling understood and supported by health care providers, having sufficient information to manage my health, actively managing my health, social support for health, appraisal of health information, ability to actively engage with health care providers, navigating the healthcare system, ability to find good information, understanding health information well enough to know what to do. Isn't that a fantastic one? Understanding health information well enough to know what to do. So all these are very different indicators of a person's ability, enablement to engage with you. They're also telling us something else very interesting and very important. They're telling us about you. It's telling us about the responsiveness of you as a practitioner and your organisation. Managing getting these data back rather than your patient satisfaction questionnaires, each of these have a very clear mechanism of what to do on Monday morning to improve services and to enable people. So it's a needs diagnostic. It reflects a patient's needs, but also the organisational health literacy responsiveness. A quote from primary care. Richard, these are the things that doctors hate most about their patients. I thought, whoops, I've upset someone. But no, not at all. This is what makes your job so challenging and interesting. And Tricia Greenhalgh, a colleague from London, described this as the description of the heart sink patient. So this is a profound acknowledgement of how damn tough your job is on a daily basis. And it's just ridiculous how much of a gap it's filling with 10,000 downloads in the first year of just a bloody questionnaire. That's terrific. So eHealth literacy, exciting. So we got a signal in our work with health literacy that eHealth literacy or internet was important, but a signal wasn't strong enough in our data collecting exercise. So we combined forces with the Centre for Human Computing in Copenhagen University and a great PhD scholar, Ollie, and senior researcher Lars, also then collaborating with a group in Canada and then a group, Paul Turner in Tassie. So again, we did this kind of process here, the concept mapping, the grounded approach, put theory behind over there, talk to real people, real clinicians. This included one workshop with Tricia Greenhalgh's department in London, which is one of the hardest we've done in the world. It was actually equally as hard and challenging as we've run these with people with brain injury. We're in about 300 of these from the north and east and south in Thailand to many conditions, many settings, where we get really grounded, clear information about what's going on out there in the community. We also did an e-consultation, included 22 countries. We had a ridiculous number of respondents, and the poor PhD student had to sort the most amazing set of data to confirm what people were saying in one-on-one workshops. So these are the health literacy dimensions that we've come up with. We're pretty confident with these because of the global engagement and our previous tools with the way in which they're constructed, that these are pretty well capturing what's going on there. So I'll just read the titles as a taster. You can get these slides later. So the first group is end user capabilities. Knowing about one's own health is important for e-health literacy, engagement in e-technologies. Then handling information. B is the second group, end user relationships to digital systems, digital services that suit individual needs, access to digital services that work, and then end user interaction experience in digital services, motivation to engage with digital services, feel safely in control of data and systems, know how to engage with information and systems. So that's what we discovered from an enormous range of consumers of all types as the dimensions of e-health literacy. So how can we put these ideas into new technologies? Well, collaborating with Krishnik and Turner of their piece of work about the user task context matrix for health IT systems design, where the programmers are really supported to think about being fit for purpose. So you've got the user dimension, you've got the task dimension, and the healthcare context dimension, really supporting and forcing the programmers and the excited clinicians about developing tech to produce something which might be useful. So when we partnered with this group, thinking about fit for purpose, how can we include health literacy, we have combined it like this. So this is a little bit tricky, and I don't usually go in for big complex diagrams because it's hard for me to explain them. But let's just try to go through this. So we've got three elements, three circles there. We've got the context in the middle, we've got the user, and we've got the task. So from the user perspective, if we can deeply understand the degree to which a person knows about their own health and the ways in which they can't and do and don't want to handle information, we get really clear information about this front-end issue. And if we understand the task there on the right, digital services that suit individual needs, and think about the access to digital services that work, we think of those elements. Then in between, the motivation to engage, what are the determinants of that? How can we make people feel, number 6, feel safely in control of data and systems, and how can we ensure that we know how to people engage with information systems? Now, people will have very, very different levels of all these. Some will be hot on others and weak on others, just like Mr. Average doesn't exist in your clinical practice. So with the health literacy, some people can have no idea, they can't read, but they've got a son who's a doctor. Therefore, they have no idea, but they're incredibly supported. So on average, they have profound and great health literacy. So think about this from this perspective as well. I'm running out of time, but the concept of e-health literacy adds value to health IT design processes in at least 3 ways. During requirement gathering, a structured approach can be applied to propose, discuss and test assumptions about the characteristics and capabilities of end users of e-health systems and applications. And during participatory design, co-creation, the selection of participants can take into account different levels of health literacy across typical intended users. So if you do a survey of the people you intend your product for, you actually make sure you have the full range of health literacy competencies at the table with you at the computer, doing the wireframes and building your system. Then there's potential range of users defined in terms of health literacy capability are considered explicitly when modelling user requirements and or more specifically envisaging classes of end users of the system. So you have different capability requirements or different enablement levels, or your e-system is really easy and simple for those people who want it easy and simple, turning on is hard enough. For those people who are savvy, they have a much more savvy system, so it's a user system responsiveness. So imagine evaluating your e-health intervention using this kind of a framework, and imagining if you're deciding you're going to choose an e-health intervention, given the options out there, you were able to assess your tenders and your applications using this as a framework, which is what we're recommending in the paper. I just want to make a comment here that no one here in the room, I expect, has ever studied how to develop an intervention. You can't do a degree in intervention development or a master's or a PhD, really. You can do a PhD, some people into it. But there's a whole technology around starting with understanding the needs of consumers. Is there a need for this technology? Is your technology being built because there's some very enthusiastic programmer, clinician or geek who's developed because they're excited about that? Or was it built from first principles because there's an absolute need out there for it? So in thinking about our earlier health literacy work, we have an ARC linkage project across 9 organisations where we're doing a whole range of health literacy assessment. Here's the 9 dimensions I mentioned before. And we go out there and we present to frontline clinicians who care after collecting data from their patients, and we do cluster analysis and we develop clinical vignettes. So we get your data, we develop clinical vignettes, and we ask our best frontline practitioners, do you recognise this patient? Because we're using their data and we're using their clinical vignettes, and they tell us great stuff. So the intervention development here is about using the best brains and the hearts and minds of our frontline practitioners on a daily basis who will never ask the question of what they do. So many of you are working under extraordinary situations in tea rooms and cupboards to generate outcomes with limited resources, doing fantastic innovation. So the whole piece of work we call the Ophelia process is to generate fantastic innovation from our frontline practitioners. And this is to develop the Victorian Health Literacy Framework, and we'll build this into this kind of model. And of course, everyone knows the 3 steps of implementation. Hands up who doesn't, don't have to do that. But it starts with product design, ends in scaled up and implemented, and people expect it. It's a miracle it's going to happen. But in settings where you've got massive organisational barriers which will stop your implementation success. There's the high need for innovate, but when you've got a high need for the innovation and a high readiness for change, you can get it in there. Or there's little obvious benefit for innovation, but when the innovation is so good it's sucked into practice, and that's our plan, to actually have complete routinization through the innovation being fitting hand in glove. We work in incredible partnership with the community and clinicians like yourselves to generate innovations from first principles, because there's no struggle to implement it because it's you guys who made it up and invented it. You already like it, you're becoming a champion and leader, and it's implemented because it's hand in glove. So that's a different approach. So 3 steps of implementation, version 2, you identify a need, a very carefully constructed need to get it embedded in the system using planned, structured, resourced and co-created for success. My dream is for all interventions are developed. This is Richard's dream. It's a bit strange for a meeting like this, but all interventions are developed based on identified need. The implementation strategy is thought through before design starts. Implementation is proven before expensive RCTs to implementation optimisation trial, please, before going to RCT, but not that our NHMRC would ever let you do that anyway. Co-created for end users, who are the patients and the health professionals, fit for purpose, so good it's sucked into practice and no one knows it's there. No one knows it's there. That's fantastic, isn't it? It is so good, it just becomes like breathing, and it's just there as good practice. So you force equity, you force better practice, because it's so good, it just becomes normalised. Here's my last slide. So what are you doing? I'm using my device. What is your device? My device is the sky. Does your device have any applications? Yes, it has sun, moon, clouds, and birds. And do you have to recharge your device very often? I don't ever recharge my device, it recharges me. So that's where the future is, I hope, with eHealth. Thank you.